Hey everyone, today we are going to be talking about intracranial EEG monitoring. So we're going to go over the criteria and definition of this. We'll go over SEEG, subdural electrodes, possible complications from both, bone flap replacement versus removal, and some nursing considerations for all of the above. So just a disclaimer, please review the patient's chart in detail. Each patient situation is unique and the surgical plan varies for each patient. Also, the techniques for this may evolve over time. So the basic inclusive criteria for phase 2 epilepsy surgery, the patient has to have medically refractory epilepsy, so they've tried 2 or more anti-seizure medications. Their seizures do significantly impact their quality of life. They have a presumed potential for seizure reduction, and we've gone through surgical epilepsy conference, and the team has agreed to offer this to the patient. Also, the patient has to be willing to participate in the study. So phase 2 intracranial monitoring, it's an invasive procedure that's performed when pre-surgical evaluation hasn't led to a definitive seizure localization and a comprehensive surgical plan. So basically, we're going to do more investigation with this study. So stereotactic electroencephalography, also known as SEEG or stereo EEG. So this involves depth electrodes. This began in the 1950s in France. It's a fine, flexible plastic tube with a rigid stylet that can be removed. So they're attached to wires that carry the currents from deep and superficial brain structures to an EEG amplifier. So you can see on this picture that there's some metallic areas on that electrode. That's what's recording. These are available in different contact amounts. So usually it's 8 to 16, and they're usually about 2 millimeters apart. And the diameter is about the size of a spaghetti noodle. So indications for SEEG, we suspect that the patient has a deep-seated or difficult to cover location of where the seizures are originating from. So this would be, in the amygdala, the hippocampus, or insula, something deep. We may need bihemispheric coverage. So we can't do 2 craniotomies to do coverage with a grid. So we'll use SEEG. Previous studies have failed to line out where the seizure onset zone is, so we need more coverage. Also, the pre-surgical workup, if it reveals a non-lesional MRI, then we likely have to put in more electrodes to investigate the origin of the seizures. So the surgery overview for this, the patient is put under general anesthesia and a stereotactic frame is placed on the patient's head. You can see in this picture here, that's a stereotactic frame. Some other centers do frameless, some use a robot, but this is how we do ours. And then a pre-procedure CT scan is performed. Electrodes are placed through percutaneous twist drill holes through predefined coordinates. So we do discuss in surgical epilepsy conference where we want the coverage to be, and then the neurosurgeon pre-plans this with a special MRI and a special program called Brain Lab. So once these are placed, they're screwed into the skull so that they don't move. And then the head frame is removed, and then a post-op CT scan and or skull x-ray is performed, and this will be overlaid with the pre-procedure MRI or CT scan to make sure they're in the correct place and that we know the trajectory of them, which locations they go through to get to the desired location, because those are all recording. And then a head wrap is placed to secure the electrodes and prevent infection. So subdural electrodes, these are known as strips and grids. So these were created in the 1930s. These are small metal discs that are embedded in Teflon or Celastic usually. And these ones are connected to a thin metal wire. They're individually insulated, and then they're bundled with a plastic material tail, which is connected to a cable, and that goes to the EEG amplifier to record those signals. So strip electrodes, these ones are literally in a line, usually 1x4, 2x8. These ones are put in through burr holes, and burr holes are about the size of a dime. And these are kind of surfed over the brain with a gentle fluid pulse. They usually don't put in the strip right under the burr hole. Usually want to put it away from that location to help keep it secure and in place. For grid electrode, oh, sorry, gory picture. For grid electrodes, these are 4x4, 8x8. They can also be trimmed down to a different size per the manufacturer's instructions. In this picture, you can see they did a craniotomy. There's clips to keep the scalp back in place. You can see there's some sutures along where the dura is. And then they put the grids over the surface of the brain directly. So the placement of the grid, so prior to surgery, they do give antibiotics because you're doing a craniotomy, more at risk of infection. And then an incision is made in the scalp. And once the skin and all the underlying tissues have been cut and moved out of the way, a drill is used to make burr holes in the skull. These burr holes are then connected by a saw to get that bone off. And then once the bone is removed, the grids are placed directly on the surface of the brain and then secured with sutures to the edge of the dura. Strips and depths can also be added at this time. The bone flap, which is also the skull bone, can be re-implanted immediately or placed in cryopreservation storage and replaced at the end of the study. A duroplasty or mesh can be placed, and then the scalp is sutured closed over the opening, and an air knot is used to keep the electrodes in place along the scalp. A subgaleal drain may be used to assist with post-op fluid collection. So this is basically in between the scalp and the bone or just under the scalp. And then a standard head wrap dressing is applied. So just a summary of comparing these methods. SEEG is better for measuring deep brain structures and covering a larger sample of the brain. It's less invasive because there's no craniotomy. There's less post-op pain, fewer complications. When patients do report pain, they often say it's in their forehead, like in their temples, because that's where the frame was placed on their head. For grids and strips, this provides good coverage of cortical areas, the surface of the brain. It's the first choice for cortical mapping of eloquent cortex. Eloquent just means tissue that we cannot remove because it's essential. So, areas of motor, sensory function, language, and speech. Or it's also used for measuring the boundaries of the seizure onset zone. This is still kind of the gold standard in the US is to use grids and strips. So just a little overview of the bone flap options, why we might decide one over the other. So the bone map, when it's immediately replaced in these grid studies, it's been shown to increase the risk of bone flap osteomyelitis, which then, it has to be removed and a titanium plate has to be used instead. Also, it tends to alter the EEG characteristics, and it's been shown to lead to a longer length of stay. So the idea is that the grid tends to create more edema in the brain. And so it kind of shifts the grid and it might change what the EEG looks like. And so the patient may need to stay longer to capture more seizures. And then you may need a CT scan as well to see where it's moved at. And then also it increases, the risk of mass effect of the brain. So that can cause a midline shift. You've seen this before where the patient gets lethargic, they may have hemiparesis, and there's the possible need for emergent decompression, which we did have about a year ago, where they had to take the bone flap off and put a drain in instead. So if the bone flap is reimplanted after electrodes are explanted, the risk for the patient is that they could, get brain injury from putting pressure on that part of the head where the skull is not protecting it. So for patients with severe postictal agitation or, significant risk of falls, they may be less likely to keep the bone flap off. So special considerations for patients without a bone flap, they need a sign over their head of bed that says, no bone flap on whichever side it is. Do not turn the patient on the side of the missing bone flap. We don't want to put any pressure in that area. The head of bed should be at 30 degrees, ideally not flat. Use pillows to help reposition them during seizures. We want to prevent pressure from being on that head or from them striking the side of the bed. And then if in place, monitor the drain. This is important to help prevent edema, especially in the face. And then for all patients, seizure patients, we want to use all of our fall and safety precautions. Unfortunately, our patients can't wear a helmet when they don't have a bone flap because of the implanted electrodes. It puts too much pressure on it, and it can actually be more dangerous for them. The head wrap needs to stay in place. Always reinforce it with Curlex if there's a lot of drainage or if it's displaced and page neurosurgery. Only the neurosurgeon changes these head wraps for our patients. And then comparing the rate of complications for both. So for SEEG, there was a meta-analysis study out of Cleveland Clinic where they looked at 30 different articles. The total patients in all the studies was about 2,600. The average amount of electrodes per patient was 10, which is pretty accurate for our center as well. The average length of monitoring was 11 days, but the range was 2 to 33. So it's a bit longer than patients with the subdural grids. So when you look at the rate of complications, technically the highest one is intracranial hemorrhage. The most common type of hemorrhage for this patient would be intracerebral, so within the brain tissue. And then superficial infections and neurologic infections are the next most common. But if you look at the pooled prevalence for it, it's about 0.9%, so it's still technically less. Permanent and transient neurological deficits are about the same prevalence. So these are usually motor weakness or sensory changes. Other complications are about 1.1%, but these include things that are usually complications for video EEG monitoring, but still aren't common. So like DVT, PE, UTI, psychiatric changes. All of these were transient and resolved with treatment. And then hardware-related complications and status were the next most common. For the status patients, 0.3% was only 3 patients in the study. So essentially, the overall risk of surgical morbidity with SEEG is 1.3%. So in other words, that's one complication for every 29 patients implanted. And comparing to our center, we've never implanted more than 8 patients in 1 year. So grids and strips. This was a meta-analysis study out of Cincinnati Children's in Ohio. They looked at 21 studies of patients with implanted subdural grid electrodes. They may have had a few depths or strips, but the large majority of them were from grids. This study had about the same as the previous one, 2,500 patients. Only 6 of the studies were pediatric, so they were mostly adults. The average length of monitoring is 5 to 17 days for grids and strips. The number of electrodes is about 52 to 95. So that's including all of the little metal contacts on the grids. So the rate of complications, when you look at what's most common, it's the transient neurological deficits. And it's expected that these complications are likely underreported because they're often considered just a part of the grid study, that you're going to get transient motor and language deficits, mild to moderate headaches, and even CSF leaks just based on the nature of the study. Permanent neurological deficits were about as common as SEEG. Intracranial hemorrhage was at 4%. So the most likely type is subdural hematomas because we're putting this in the subdural space. Most of these hematomas were symptomatic and required surgical intervention. Elevated intracranial pressure is the next most common. That's related to all the edema, mass effect that happens with the grids. So that's 2.4%. Infections were the next most common. They were usually some sort of abscess, in the area where they did the surgery at. So it is a bit higher for these patients. About 3% of them required additional surgical procedures to manage all these adverse events. So if we're comparing these, just a little summary that you can read through, SEEG does appear to be a bit safer for the patients. Subdural electrodes do carry more risk. If you're looking at the mortality from patients in both studies, the SEEG patients are more at risk with the intracerebral hemorrhage, which does tend to be the most common complication. And then for the subdural electrode patients, increased intracranial pressure is the most severe, risk of mortality. So patients were more at risk with over 67 electrode contacts related to the subdural electrodes. And this actually, this doubled their risk if they had over 67 electrodes for hemorrhage and for infections. So phase 2 nursing considerations. So this is an overview of neurological assessment that we should be doing with the patients. This should be done at shift handoff with the offgoing RN every 4 hours as ordered, at every seizure until back to baseline, and with any neurological changes. The most important symptoms to report are change in level of consciousness, sudden confusion, weakness, and aphasia. So for the seizure assessment, this is just an overview, a refresher that you can read through. You guys all know this. This is the sign on the board for the ictal assessment or during the seizure, and then the post-ictal assessment. These are more examples of higher level of functioning tests that you can do to see if they're back to baseline. And then caring for the phase 2 patient. So vital signs should be done per IMU level of care, usually every 4 hours. Please report any changes. For the head wrap, as always, assess for drainage, reinforce as needed, and page neurosurgery if it needs to be changed. Dressings are only changed by the neurosurgeon. For peripheral IVs, it's ideal to have 2 just in case. Always assess for patency throughout your shift and ensure IV access prior to cortical brain mapping. So when we do brain mapping, we're more likely to cause a seizure. So it's ideal to be prepared to give the medication. And then I'm not going to read through these, but these are the usual safety tips that we have for, all of our patients. Same with the seizure precautions. The only thing to note is that that big EEG electrode bag that they have with them, please keep it in the bed with the patient at all times, not on the bedside table and not hanging off of the rail because this is dangerous for the patient. And then for the PRN orders, please review all the orders prior to paging. We definitely want to treat, nausea and vomiting to reduce intracranial pressure. If patient suddenly develops severe pain, please contact neurosurgery as well as neurology. And then page for any headaches while the patient is sitting and standing, meaning that they only have the headache with sitting or standing, or if there's a lot of clear drainage on the dressing, because this could be a CSF leak. And then, of course, monitor for infection. So any fever, of course, you can't really see redness, swelling and drainage at the site of the incisions, but you can see it on the head wrap. Sometimes you can see it a little bit under the head wrap. Also monitor for fever, stiff neck or headache. These could be signs of meningitis. Monitor the drain and notify neurosurgery for any signs and symptoms of infection or drain related issues. The drain is usually placed for the GRID patients. If they have facial edema that's starting, you can take pictures of it each shift so that, every shift can compare what it looks like, if it's getting worse or not. Page for any change in level of consciousness, confusion, sudden weakness, and or aphasia. These could all be symptoms of significant pressure in the head. And then for pulling electrodes, of course, page epilepsy and neurosurgery if the patient is pulling at the electrodes, the head wrap, or hits their head hard. where the electrodes are placed. Use pillows around the bed rails to pad everything. Put mittens on or wrist restraints and page the doctors if needed. They may order an IM or IV medication to help calm the patient, such as Haldol. This is an overview of increased intracranial pressure because we don't see it very often. Please read through this. Essentially, the early signs are typical for neurological changes, meaning the change in level of consciousness. If the patient's more lethargic, restless, confused, we're very concerned. If they have an acute headache, that's worse with things that increase pressure like coughing, sneezing, laying flat, or any exertion. And if that's accompanied by nausea and vomiting, if they have any pupil changes, weakness, sensory deficits, of course, these can be difficult to separate from the surgery itself or, results of having seizures, but a combination of these things, we're more concerned, do they have increased pressure? So key points from this lecture. The overall risk of complications for invasive EEG electrodes is low. SEEG patients are more at risk for intracerebral hemorrhage and infection, while the subdural electrode patients are likely to have transient neurological changes such as hemiparesis or aphasia. They're more likely to have subdural hematomas causing pressure or infection or increased intracranial pressure. Patients without a bone flap need a sign above the head of the bed indicating no left or right bone flap, and they cannot be turned on the affected side. Neurological assessment is crucial for the safety of the patient, especially report changes in level of consciousness, confusion, aphasia, and motor weakness. If you guys have any questions, feel free to email me. I can ask any questions of the doctors as well and of the neurosurgeon. Thank you.
Verify consent before application. Center the belt across the mattress with the waist strapped towards the head of the bed. The back pad should be positioned with the words "this side up" are facing upward. Wrap the connecting straps around the part of the bed out of the patient's reach. Thread the strap over the top around the frame and through the lock. Secure the lock. Repeat the same procedure on the opposite side of the bed. The belt should be positioned at waist level. Bring the belt around the waist, feed the strap through the lock, and secure. To unlock, insert the key and turn counterclockwise. Remove the belt. When ready to remove the strap from the side of the bed, unlock and remove the belt. Repeat on both sides of the bed. Verify consent before application. It is important to become familiar with the straps and the waist belt. Using the belt end of the strap, place it through the first loop and then tuck the excess piece behind the chair and bring the belt loop to the front of the chair to then place the belt through. Repeat the same procedure on the opposite side of the chair. Always use the first loop when tying the strap to the chair. The belt loops should be snug to the chair. Use the belt provided to thread through the straps. The belt should be positioned at the back of the chair. The patient can now sit in the chair and place the belt around their waist, thread the belt through the lock so that the belt is snug, and lock it. The patient should be provided the keys so that they are able to unlock the belt when needed. To apply the wrist restraint, position the patient's wrist on the padded cuff portion of the restraint. Use the Velcro fasteners on the outside to secure the cuff. Then fasten the clip. Ensure the cuff is snug and 2 fingers can be placed between the cuff and the patient's wrist. Place the strap around a part of the bed frame, fold the loose end in half, create a loop, and cross it over as if tying a shoelace. Pull to tighten. The knot should release with one pull of the loose strap. To tie a quick release with a double knot, place the strap around a part of the bed frame, fold the loose end in half, create a loop, and cross it over as if tying a shoelace. Then, using the tail end of the tie, bring it through the existing loop and pull tight. The double knot should still be able to be released by one pull of the tail end. Medical restraints are used for patients who are pulling at their tubes or impulsive without the intent to harm. The orders need to be initiated within 12 hours of the restraints. Restraints need to be renewed each day. The doctor needs to evaluate every 24 hours. Monitor the patient as frequently as possible. Your RN assessment needs to be completed every 2 hours. Behavioral restraints are for patients that are violent or self-destructive behavior. They might be aggressive or assaultive towards you with the intent to harm. The provider needs to put eyes on the patient within 1 hour of the initiation. Continuation beyond 4 hours requires assessment by the RN and a new order by the MD or psychologist. Beyond 8 hours requires in-person evaluation by the psychologist and a new order every 8 hours.
Today we're going to be discussing the application and removal of the TR band. The TR band is used to apply low pressure hemostasis at the site of the radial artery access and sheath. And the reason why we maintain low pressure or patent hemostasis is to attempt to reduce the incidence of radial artery occlusion following radial artery catheterization and angioplasty. Although radial artery occlusion is thought to be rare and mostly asymptomatic, it is important when we are dealing with reaccess of the radial artery at a future time. Low pressure hemostasis or patent hemostasis enables blood to flow through the radial artery while compression is applied in order to reduce the likelihood of radial artery occlusion. To assist with managing hemostasis, Terumo has developed a dual balloon radial artery compression device designed to help manage the cessation of bleeding from the access site under low volumes of pressure. In addition, the TR band allows the user to control the pressure applied by incrementally titrating air throughout the recovery period. The TR band is unique in that it can manage two important elements concurrently and consistently: hemostasis and maintenance of low pressure. After removing the dressing, we will withdraw the introducer sheath about 2 to 3 centimeters in order to properly place the band on the patient's wrist so that there is no obstruction when seating the band. The TR band must be positioned differently when used on the left or right wrist. When attaching the device, ensure that the Terumo logo on the support plate is closest to the patient's little finger or ulnar side of the wrist. It is also important to align the green marker about 1 to 2 millimeters proximal to the puncture site and fix the strap on the wrist with the adjustable fastener. The green dot is located on the center of the compression balloon. Placement of the green dot is important because it ensures that the balloons are appropriately located on the radial artery to control bleeding. Now that the band location is properly secured, I will fill the inflation syringe with 15 to 18 mLs of air and slowly inject the 15 of 18 mLs of air into the air port of the TR band and simultaneously remove the radial sheath. The air will be fully inserted when the sheath is completely removed. The goal is for bleeding to cease when the sheath is completely removed from the patient's artery. Once we have fully inflated the TR band and confirm that bleeding has stopped, we will now ensure patent hemostasis. We will do this by removing 1 cc per second while keeping an eye on the access site to watch for bleeding. Once we see a flash of blood, we will inject 1 to 2 cc's of air back into the balloon incrementally until bleeding stops. This will help to ensure patent hemostasis. This again can be confirmed with a reverse Barbeau test. The patient is now ready to go to recovery. When it is time for the TR band to be removed, we will begin by removing the air in the balloon to check for hemostasis. I will start by removing 3 to 5 mLs. Since I have not seen any bleeding, I will continue to remove air from the balloon. If bleeding is still seen, we will insert enough air to restore hemostasis and once again confirm patent hemostasis. After 15 to 30 minutes, the removal process can be repeated. Now the air has been completely removed from the band and bleeding has stopped, we can unfasten the Velcro band, slowly remove the TR band by lifting toward the palm of the hand, and lastly, applying a sterile dressing.
This video is going to explain how to flush a patient's pericardial drain per our guidelines. In order to do that, you'll need to gather your supplies, which include a 10 cc flush, a couple of alcohol swabs, and a red cap. So prior to flushing the patient's pericardial drain, you'll need to validate the order. So within the order, you will find the frequency with which you need to flush, the flush solution, which will either be heparinized saline or normal saline. In this example, we're going to be using normal saline, and the volume to be flushed. So now I'm ready to flush the patient's pericardial drain. So I'm going to remove the patient's red cap, grab my alcohol swab, flush, clean. Okay. So this is normal saline. I'm going to attach my syringe here. Okay. I'm going to turn it off towards the drainage bag and just slowly flush my 10 cc's towards the patient. If you meet resistance while flushing, please stop, discontinue your flush, and notify the provider. So now I'm ready to withdraw the same amount that I flushed with into the same syringe. So I'm going to slowly withdraw and try to get back the full 10 cc's that I flushed with. If you are unable to withdraw the full 10 mLs that you flushed with, that is okay. Just note the volume with which you are actually able to withdraw. Okay, so once I've recollected my insertion flush, I'm going to clamp, clean with alcohol, and apply a new red cap. Once this is done, now you will let the bag passively drain down into the bag and continue to observe your drainage. And then you will continue to document your flush and the amount collected afterwards as well within Epic. In order to document your pericardial drain, you're going to open up an LDA here, close suction drain, and label it as pericardial. Okay, you're going to complete the site description, the dressing type, the dressing status, the drainage appearance, and the status, all in here as you proceed to assess the drain on your patient. In order to document the flush and output, you are going to go down here, intake, and document 10 mLs. So this indicates the 10 mLs that I injected into the drain, and the output is the 10 mLs that came out as I withdrew my syringe to collect the flush. If you were unable to collect your full 10 cc's of flush that you instilled, that is okay. Just indicate here how much volume you were able to actually pull out. So if it was only 8 mLs, you'll indicate that here. Okay, once you file this, okay, you will need to, in order to document the drainage collected from the gravity drainage, you will have to insert another column and document your output. So if a couple of hours later you got 20 cc's of fluid that you noted that were drained, you would note that here and document that. So after I've filed that, I can go to my summary page and look at the intake and output of the drain. So in here, it indicates that 10 went in and 28 came out. So that is a combination of the 8 cc's that came out with the flush, and then an additional 20 cc's of volume that came out by gravity.
Intravascular pressure monitoring setup with the TrueWave transducer. Part 1. Priming the system. Bedside measurement of intravascular pressures is a basic tool in the care of the critically ill patient. TrueWave disposable pressure transducers can be paired with Edwards vamp systems to create a single integrated pressure monitoring and closed blood sampling system. TrueWave transducers are available in single, bifurcated, and trifurcated forms to suit your patient needs. The following animation demonstrates best practice in the setup of a single TrueWave disposable pressure transducer. Here's what you will need to get started. One TrueClip holder or an arm mount strip, a 500 or 1000 milliliter normal saline IV bag, a properly sized IV bag pressure cuff, and appropriate cable that connects your bedside patient monitor to the TrueWave transducer. Prepare the TrueWave transducer using the following 5 steps. Step 1. Using aseptic technique, remove the transducer kit from the sterile packaging and ensure all connections are secure. Step 2. TrueWave transducers can be mounted on either an IV pole or on the patient's arm. The setup procedure is the same. This video demonstrates the pole-mounted method. Insert the TrueWave transducer into a mounting backplate that is secured on an IV pole. Step 3. De-air the IV bag and prime the TrueWave system. Invert the normal saline IV bag so air raises to the base of the bag. Anticoagulation per institutional policy. Spike the IV bag with the fluid administration set, keeping the drip chamber upright. Open the roller clamp on the IV set. Open the vent port by turning the stopcock toward the patient's pressure tubing and away from the transducer while leaving the vented cap in place. While keeping the IV bag inverted, gently squeeze air out of the bag with one hand while pulling the snap tab flush device with the other hand until air is emptied from the IV bag and the drip chamber is filled at least halfway, or per institutional policy. Insert the IV bag into a pressure infuser bag and hang on an IV pole approximately 2 feet or 60 millimeters above the patient. Confirm that the IV bag hook is securely hung on the IV pole. If not secure, the IV bag could fall out as the pressure bag deflates. Do not inflate the pressure bag. Step 4. Prime the TrueWave system to gravity to avoid microbubbles in the line. Pull the snap tab flush device to deliver the flush solution through the TrueWave transducer and out through the vent port's vented cap. Remove all air bubbles. Close the vent port by turning the stopcock toward the cap. Holding the pressure tubing in an upright 45-degree angle, pull the snap tab to flush the remaining part of the line through the end of the tubing. Visually inspect the line to ensure that all air bubbles are removed. Pressurize the IV flush solution bag to 300 millimeters of mercury. Turn stopcock toward the pressure bag to lock off air pressure. Intermittently assess pressure during use, as pressure decreases when fluid leaves the IV bag. Low pressures in flush bag may lead to dampened pressure waveform and incorrect readings. Pull the snap tab to flush the system under pressure, while tapping on the tubing and stopcocks to remove any residual bubbles. Step 5. Replace all the opaque vented caps on the side ports of the system stopcocks with non-vented caps. We have now completed priming the system. Please continue to part 2 of this video series, Calibration, to complete the setup of the TrueWave transducer with the bedside physiologic monitor. Intravascular pressure monitoring setup with the TrueWave transducer. Part 2, Calibration. Before connecting the TrueWave transducer to a bedside monitor and calibrating the system, it's important to prime the system properly. If you haven't already done so, please follow the steps in Part 1 of this video series, Priming the System, to complete this procedure. Now that we have completed priming the system, we will need to calibrate the TrueWave transducer with the bedside physiologic monitor using the following 8 steps. Step 1. Connect the appropriate TrueWave reusable pressure cable to the proper port on the bedside monitor. Then, connect the opposite end of the reusable cable to the TrueWave transducer's white connecting cable. Step 2. For intravascular pressure monitoring, level the transducer to the patient's phlebostatic axis, which can be found at the midpoint between the anterior and posterior chest wall at the 4th intercostal space. Note, it's important to maintain the level of the transducer with the phlebostatic axis at all times while monitoring to ensure accurate pressure readings. It is a best practice recommendation to use a carpenter's level when leveling the transducer. Step 3. The true wave transducer must be zeroed to remove the effects of atmospheric pressure. Open the stopcock above the transducer to atmospheric air by turning the stopcock toward the patient's pressure tubing and away from the true wave transducer. Then remove the non-vented cap. Perform this maneuver while maintaining sterility of the cap and stopcock port. Step 4. Select the zero function on the bedside monitor and confirm that the monitor's pressure channel waveform and numeric value display 0. Check monitor calibration using the procedure recommended by the monitor manufacturer. Step 5. Close the stopcock on the true wave transducer toward the vent port and then return the non-vented cap. Step 6. If not already connected, connect the true wave's pressure tubing to the patient's catheter. Step 7. Confirm the appropriate pressure waveform and numeric values are present. Step 8. Perform a square wave test to assess the frequency response of the system by pulling the snap tab and releasing quickly. Please be advised that poor dynamic response can be caused by air bubbles, clotting, excessive lengths of tubing, excessively compliant pressure tubing, small bore tubing, loose connections, or leaks. Confirm the pressure channel has the appropriate label, scale, alarm settings, and color coding for physiologic pressure being measured. The calibration procedure is now complete. The True Wave disposable pressure transducer is designed with the clinician in mind, from its ergonomic profile that fits in the palm of your hand to its cable connector that attaches and disconnects easily. True Wave disposable pressure transducers can also be paired with a VAMP Plus kit or a VAMP kit. The Venous Arterial Blood Management Protection System for a complete and reliable closed, needleless blood sampling system with accurate pressure readings in one complementary unit. Please see our website for additional demonstrations of the VAMP systems. At Edwards Life Sciences, everything we do is focused on providing the clear information you need, how you need it, in the moments you need it most.
The VAMP Adult System, Closed Needleless Blood Sampling. The innovative Edwards VAMP Adult System is the first generation of venous arterial blood management protection. The VAMP Adult System standardizes blood sampling techniques for consistency, accuracy, and safety you can depend on. The VAMP Adult System is available with or without an Edwards True Wave disposable pressure transducer for a complete solution that protects clinicians from unnecessary exposure to blood, provides for patient safety, and protects your hospital's bottom line. Setup, priming, sampling, and flushing are quick and easy with the VAMP Adult System. The VAMP Adult Reservoir has a 5 cc capacity that allows for ample clearing volume and can be used at the bedside, next to the patient, right where you need it. The self-sealing, pre-slit, non-latex Z-Site sample port is designed to enable the collection of undiluted samples while greatly reducing residual blood buildup and reducing the chance of infection. The blunt cannula design provides safety during the process by eliminating accidental needle sticks associated with blood sampling. The direct draw system with blunt cannula provides an extra level of efficiency and convenience by enabling blood to be pulled directly into a vacuum tube. The Edwards VAMP family of closed blood sampling systems is designed to protect the patient and the clinician from complications associated with traditional sampling techniques. Traditional sampling risks in the critical care setting involve removal of the stopcock cap and storing so that the inside of the cap remains sterile, accessing the sample port, storing the cap, and connecting the waste syringe places the system's sterility at risk. Drawing the clearing volume involves the risk of an inconsistent amount of clearing volume drawn, and the risk of diluted lab samples. Discarding the clearing volume wastes the patient's own blood, thus increasing the chance that the patient will require a transfusion. Connecting sample syringes to draw samples requires additional access that increases the risk of contamination at the port. Transferring a blood sample to a vial via a needle puts the clinician at risk for needle stick injury and bloodborne pathogen exposure. Flushing the port to clear residual blood also puts the clinician at risk for bloodborne pathogen exposure. Replacing the stored cap puts the system's sterility at risk for contamination of the cap or sample port. Now that you've been introduced to the VAMP Adult system, let's start our in-service by setting it up. To begin, remove the VAMP Adult system from the package using an aseptic technique. All connections should be checked, secured, and tightened. Close the reservoir plunger and confirm it is in a locked position. Mount the VAMP Adult system on the IV pole or simply set the reservoir on the bed next to the patient. Now that you have set up the VAMP Adult system, let's learn how to prepare and use the system. The first step is priming. To begin, first squeeze and hold the flexures to slightly raise the plunger to facilitate flow of the priming solution. Now, with the shutoff valve in the open position, which is parallel to the tubing, hold the sampling site above the VAMP reservoir at a 45-degree angle. Next, provide flow by pulling the flush device of the True Wave disposable pressure transducer. Slowly deliver the priming solution to remove air. When the air is gone, close the plunger and ensure all air is removed from the system. Then connect to the patient's catheter. Once the system is primed, you are ready to draw the clearing volume. Note: depending on the procedure and policy of the hospital, a direct draw unit, blood collection tubes, syringes, blood transfer unit, alcohol preps, and needleless cannula will be needed. First, firmly squeeze the flexures and slowly draw the reservoir open over 3 to 5 seconds. Then, close the shutoff valve by turning the handle perpendicular to the tubing. This is to prevent aspiration of blood from the reservoir. You are now ready to draw the blood sample. To begin, swab the VAMP needleless Z-site sampling site with disinfectant such as alcohol or other antiseptic, depending upon hospital policy. Then push the cannula with the syringe or direct draw unit onto the sample site. Note: do not use a hypodermic needle through the sampling site. Now, put the vacuum tube into the direct draw unit. Repeat if necessary to complete the blood study requirements. After the last sample has been drawn, grasp the VAMP direct draw unit by the cannula and pull it straight out. Once you have the samples drawn, you need to reinfuse the blood and clear the line. To do this, open the shutoff valve by turning the handle parallel to the tubing. Next, over 3 to 5 seconds, smoothly and evenly push down on the plunger until the flexures lock in place in the fully closed position and all of the fluid has been reinfused into the line. Finally, flush the VAMP system clear by pulling the flush device on the True Wave transducer and swab the sampling site to ensure the removal of any excess blood left on the sampling port. Now that we have learned how to take a sample using the direct draw method, let us review the method of taking a sample using a syringe and blood transfer unit, or BTU. First, gently squeeze the reservoir plunger flexures together. Smoothly and evenly pull up on the reservoir plunger until the plunger stops and the reservoir has reached its 5 cc volume capacity. Once the clearing sample has been drawn, close the reservoir shutoff valve by turning the handle perpendicular to the tubing. This will further ensure that the sample drawn is from the patient and not the reservoir. Swab the VAMP needleless sampling site with disinfectant, such as alcohol or other antiseptic, depending upon hospital policy. Next, obtain an individually packaged VAMP needleless cannula and luer tip syringe. Using aseptic technique, peel open the cannula pouch. Pick up the cannula by the protective shield. Attach the cannula onto a selected luer tip syringe by aligning the cannula luer lock to the luer tip on the syringe and twisting until secure. Ensure that the syringe plunger is depressed to the bottom of the syringe barrel. Push the cannula into the VAMP needleless sampling site and then draw the required volume of blood into the syringe for sampling. Note: do not use a hypodermic needle through the sampling site. To remove the syringe cannula assembly from the sampling site, grasp the cannula and pull it straight out. Once the last sample has been drawn, open the shutoff valve by turning the handle 90 degrees so that it is parallel to the tubing. Smoothly and evenly push down on the plunger until the flexures lock in place in the fully closed position and all fluid has been reinfused into the line. The recommended time to push the reservoir plunger to the fully closed position is 3 to 5 seconds. The clearing sample should not remain in the reservoir for longer than 3 minutes. Flush the line clear and swab the sampling site, ensuring removal of any excess blood left on the sampling port. To transfer the blood sample from the syringe to vacuum tubes, use the blood transfer unit, or BTU. Using aseptic technique, peel open the pouch of the BTU. Ensure that all connections are tight. Hold the VAMP BTU in one hand and push the cannula on the filled sample syringe through the VAMP BTU needleless injection site. Insert the selected vacuum tube into the BTU's opening until the internal needle has punctured the rubber disc on the vacuum tube. Fill the vacuum tube to the desired volume. Repeat filling tubes according to the requirements for the patient's blood study. Discard the VAMP BTU after transferring the blood sample from the syringe into the vacuum tubes. Discard all syringes and cannula after use according to hospital policy. For over 40 years, Edwards Life Sciences has been helping you make proactive clinical decisions to advance the care of surgical and critical care patients. Through continuing collaboration with you, ongoing education, and our never-ending quest for advancement, Edwards develops solutions that provide the clarity to help you make proactive clinical decisions.
Today we're going to do a demonstration of Coude catheter insertion. To be competent to insert a Coude catheter, you simply need to demonstrate the process for another person who is competent. To begin, you will need an order for the Coude catheter and a proper indication. The indications are, number 1, being a male patient, number 2, a history of BPH, number 3, pain or difficulty urinating and or in Foley catheter insertion attempts. For example, if you are trying to put a Foley catheter in and the patient is experiencing pain beyond what you may expect, or you are unable to pass the catheter, you're failing that attempt. And last but not least, if the patient tells you that they've had trouble in the past having a regular catheter inserted, they may tell you, I needed a special catheter or the red catheter, or they may use their word Coude. Your procedure will go a lot better for you if you get an order for lidocaine jelly via a Eurojet before you begin. Your lidocaine jelly will come in a package like this from pharmacy, and when you open it, you may notice that it looks almost like a vial of epinephrine. When you go to the dentist office and you get lidocaine, they apply the lidocaine, wait, and then do the procedure. It's the same way for the Foley catheter insertion, the Coude catheter, excuse me. So you will apply your lidocaine and then wait about 5 to 10 minutes and then come back to perform the procedure. Application of the lidocaine jelly is the first step in your process, and it is a sterile procedure. Of course, we want to have clean hands before we begin. We'd like to have our betadine ready to apply with your slippery hands and donning of your sterile gloves. To prepare your UroJet for application, you are going to remove the yellow cap from one end, the yellow cap from the other end, and simply screw the two items together. Then you will remove the cap and have this application shaped tip ready for insertion. You, with your sterile hands, will take your hold of your penis with your non-dominant hand and apply betadine around the urinary meatus. Not breaking sterility, you want to grab a hold of your UroJet and insert the tip of the UroJet into the meatus and insert the lidocaine directly into the urethra. When you are finished, you will want to gently hold the tip of the meatus closed to avoid the lidocaine from leaking back out, although a small amount of leakage will be normal. When you are finished, leave your patient for 5 to 10 minutes, remove your gloves, clean your hands, and you'll come back for part 2 of the procedure. When you are coming back to insert the Coude catheter, we do not have kits that have the Coude catheter, a tamper-evident seal, and a Foley catheter drainage bag. So you will need to collect the Coude catheter separately. They come in comparable French sizes to our regular Foley catheters. And you will need either an add a Foley tray, which is pictured here, or a Foley catheter insertion kit and discard the catheter that comes in there. Either way, it is a sterile procedure, and sterile process should be maintained throughout, including 2 trained people at the bedside for insertion whenever possible. Tips and tricks for inserting your catheter are as follows. You will notice there is a hook on the Coude catheter. You want the hook of the Coude catheter pointing up towards the umbilicus when you are inserting. Hopefully, with this shape, it would be able to pass any obstruction or the prostate if that's what was making the catheter insertion difficult. Cleanse the meatus with betadine. Have additional jelly on the tip of the Coude catheter, and then begin insertion, again with the hook up. When you are placing the catheter, you want to try to make sure that that hook stays up. And the way you will know that once it's inside of the patient that the hook is up is, number 1, your balloon port will always be up, and number 2, there is a small bump on the tip of the Coude catheter that shows you is in alignment with the hook placing upwards. When you are inserting the Coude, there are 2 major rules. You must insert all the way to the Y before inflating the balloon, and you should always see urine before you inflate the balloon. If there is no urine and you cannot insert the catheter all the way to the Y, stop the procedure and then place a urology consult. Urology will be consulted once a competent Coude nurse has attempted and failed at the Coude catheter insertion and then done a small note of subsequent documentation to explain why you had trouble. For our purposes here, we will assume that urine has come out and we will inflate the balloon. Stop if there is pain, pressure, or significant discomfort when you are inflating the balloon. When you are finished, attach a drainage bag to the end and gently pull back on the Coude catheter until you can see that the balloon is seated at the entry of the bladder. Document an LDA that includes Coude catheter insertion, and you are finished.
Today we're going to review IV administration of biotherapy drugs for the inpatient RN, taking care of a patient that is receiving monoclonal antibody drugs.
So what do you do if one of these medications are ordered? First, you should find out what the drug is, why is the patient being ordered this drug, and check if the patient has vascular access. It might be a good idea to start a fresh IV if they don't have a central line. However, a central line is not required. The level of care is varied. These medications can be given in med-surg level of care, and the patient does not necessarily need to be monitored.
Additional monitoring may be required for patients with previous allergic reaction.
This medication is not stat, so it is best to have a plan and an appropriate time to give the medication. This gives you enough time to set up appropriate staffing and either plan with your resource nurse or the charge nurse to cover you during the administration. The most common monoclonal drugs that we are seeing are Remicade, Rituxan, and Campath. These are not the only medications that you may see on the unit or administer, but these are the most common. They can be given for non-oncology diagnoses, such as rheumatoid arthritis. We are seeing it a lot for Crohn's or ulcerative colitis. Multiple sclerosis are some of the main diagnoses we're seeing these medications be given for. For drug-specific information, you can go to Micromedics. That is found on the Pulse website. Some things to consider prior to initiating therapy. For Remicade, you want to know if the patient has an active infection, and the doctor should really evaluate the risk and benefits of giving the medication if they do have infection. Also checking into whether they have a history of TB or active TB. For Rituxan, they should be screening patients for hepatitis. And then for Campath, the most recent CBC, their urine, creatinine, also things like TB infections that they might have. Some of the complications that can be experienced with Remicade is the patients can get lightheaded, dizzy, have some nausea or vomiting. They might have joint pain afterward. They might develop infections later on. They can be tired afterwards. And like I mentioned, checking that TB status before initiation of the therapy. Also, just, patients with severe heart failure should not be given Remicade. And then they are at risk for developing infections afterwards.
Anticipated complications with Rituxan usually occur within the first 24 hours of the infusion and are most common with the first dose of administration.
They might have facial or oral swelling, sudden cough, shortness of breath, difficulty breathing, weakness, dizziness, fever, chills, headache, nausea, hypotension, back pain. These types of reactions occur to 35 to 40% of patients with their first treatment. You might also want to make sure that they've had hepatitis screening prior, and they should not receive Rituxan if they have a history of hepatitis related to liver disease.
With Campath,
the most common side effects are fever, chills, hypotension, tachycardia, shortness of breath, itching, rash, nausea, vomiting, and some neurological symptoms like insomnia or anxiety. In order to reduce the risk of complications with these medications, there is a standard order set that comes with pre-medication of Tylenol and Benadryl to prevent these reactions. The infusions are started slowly and usually have a rate that is being increased at specific intervals based on how well the patient can tolerate the infusion. You're going to monitor the patient carefully, keep the emergency equipment at hand, and notify the charge or resource before you begin the infusion. Here is an example of what the MAR looks like. This is a screenshot for Remicade. This is where you would see the Tylenol, the Benadryl, and the Solumedrol ordered. It is also very important to review the physician's orders, the indications, the dosage, make sure that there is an accurate weight if it is a weight-based. You want to read the administration instructions fully and have the reaction protocol available to review before the infusion starts.
The reaction protocol can be found on the form's management website and can be printed. It is D form 1575 and is linked in the MAR.
The form has specific instructions on the signs and symptoms the patient needs to report immediately to you. Make sure to provide this education to them ahead of time. You want the patient to notify you if they're having any kind of hives, shortness of breath, itching, any kind of uneasiness or agitation, any kind of facial edema, swelling in their face, lightheadedness, tightness in their chest, fever, and chills. There are two different types of reactions that are considered: mild or severe, moderate and severe reactions. So you want to make sure that you know what the mild reactions are. Those include hives, rashes, general itching. Here is an example of a Remicade infusion instructions that you could find in the MAR. You're going to use the reaction protocol. It is linked in the MAR. It is helpful to have a printed copy. It also has the signs and symptoms on it that you can review with the patient. You could also give the patient a copy of those signs and symptoms highlighted so they are aware of what they need to notify you for. The infusion rate for Remicade is only increased if the following parameters are met. The systolic blood pressure has to be within 20 milligrams of mercury from the baseline. The heart rate has to be above 60 or less than 120, and temperature has to be below 101.3 for the infusion to be increased. If the patient is unable to tolerate a faster rate, you continue the infusion at the best tolerated rate for the completion of the infusion. Remember to monitor the patient for any reaction up to 30 minutes after the infusion is completed. Hold the infusion and notify the MD if any of the following occurs. So hypotension, less than 30 milligrams of mercury, drop in the systolic blood pressure from the baseline, a fever greater than 101.3, rigors.
If symptoms improve after 30 minutes, you're allowed to restart the infusion at 1/2 of the previous rate. For example, if you are running the infusion at 80 mLs per hour and you had to hold the infusion, if the symptoms improved, you would restart at 40 mLs per hour.
Here's an example of a Remicade infusion instructions. So you're going to start the infusion at 10 mLs per hour for 15 minutes. Then you're going to take a set of vitals. Then you're going to increase the rate to 20 mLs per hour for 15 minutes. And then you're going to take a set of vitals. Then you're going to increase it at 40 mLs per hour for another 15 minutes. Do another set of vitals. 80 mLs per hour for 15 minutes, and then another set of vitals. Then you can increase it to 150 mLs per hour for 30 minutes. Then you're going to do another set of vitals. And then you can run the infusion at 250 mLs per hour for the last 30 minutes of the infusion or until it's complete. If patients have received Remicade in the past, it can start at that 250 mLs per hour, or unless they have another rate that they were able to tolerate the dose with. Patients are usually very aware that they've had these medications before. They're often given in the outpatient infusion center, and you can actually look at those records in Epic. This is an example of what it looks like in your MAR. There is the information here on your infusion instruction. This is when to increase the rate, and this is when to hold the infusion.
Each time you increase the rate, you have to document it in the MAR.
Here's another example of what a Rituxan infusion instructions would look like. Again, this order has the reaction protocol form linked to it in your MAR. It will also tell you when you can increase the infusion rate, and it can only be increased if the systolic blood pressure is within 20 milligrams of mercury from your baseline, your heart rate is greater than 60, less than 120, and temperature stays below 101.3. You would not increase the rate if these parameters are not met. If the patient is unable to tolerate the faster rate, you continue the infusion at the best tolerated rate until the infusion is complete. You're going to continue to monitor the patient for at least 30 minutes after the infusion. And at any time, you're going to hold the infusion and immediately notify the provider if the patient has hypotension greater than 30 milligrams of mercury drop from their systolic blood pressure from baseline, if their temperature goes up above 101.3, and if they have any rigors. Here's an example of how Rituxan infusion instructions are written and how you would increase the rate. This is an example for a patient who is receiving Rituxan for the first time. So when you initiate this Rituxan order, the patient would stay at the 50 mLs per hour for a full 60 minutes before you increase the infusion. Of course, you would do a set of vitals to make sure that the patient is meeting their parameters for an increase. If that works, you would increase the infusion every 30 minutes until the infusion is complete. The instructions are right here in terms of the infusion rate, when to increase it, when to hold the medication, and stop it and notify the provider. It is very important to provide patient education. And so all these medications are available on care notes. You can find that on the clinical web reference under on the Pulse website. The patient must understand the medication and the possible side effects, the symptoms to report to you during the infusion, and when to call the MD or seek medical care after the infusion or when they are discharged. It is important to make sure that you are documenting on the MAR the administration and all the rate changes and when they are increased. So you'll need to go into the MAR if the rate changes every 15 minutes and do an update on the rate. If the rate changes at an hour, you would need to go into the MAR and reflect that rate change. Make sure you're doing an IV site assessment and make sure that there's good blood return. It is not a bad idea to have a second IV available just in the case of emergency. Make sure you're documenting the biotherapy administration in the discharge plan of care. Record your patient's responses, provide the education and any interventions that were implemented.
This is the Pleurex catheter. Part of the catheter stays inside your body, either in your chest or in your abdomen. There are holes in this portion of the catheter that allow fluid to enter. The white cuff in the middle is part of the internal portion of the catheter and should not be visible outside your body. The end of the catheter stays outside your body so you can drain fluid. A valve on the end of the catheter helps keep fluid from leaking. It also prevents air from entering the catheter. You'll drain your fluid into Pleurex drainage bottles specifically designed for use with your Pleurex catheter. These bottles come in two sizes, 500 milliliters and 1,000 milliliters. Preparation and use of each bottle is the same regardless of size. Always use Pleurex bottles and drainage supplies for draining fluid through the Pleurex catheter. The active vacuum technology in the Pleurex bottles provides suction for drainage and allows you to place the bottle wherever it's most convenient during each drainage procedure. The drainage bottle features a drainage line, which you will connect to your catheter when you drain. The color of the fluid drained may vary. The Pleurex bottles come in a drainage kit that is easy to use. The kit contains the sterile items you need to drain at home, including gloves, a new valve cap for the catheter, alcohol pads, gauze, a foam pad, and a sterile dressing. The kit also contains a blue emergency slide clamp. This clamp should be used only in an emergency to close the catheter if it is somehow cut or damaged. See the instructions for use for more information and notify your nurse or doctor immediately if you decide it's necessary to use the emergency clamp. The drainage procedure should be done using a clean technique. Before beginning each drainage procedure, remove any rings and wash your hands thoroughly with soap and water for a full minute, even though you'll wear gloves during the drainage procedure. Dry your hands using clean paper towels. Remove the dressing from the area around the catheter and discard it. Be sure not to tug on the catheter. Support the skin while removing the self-adhesive dressing. Gently grasp one edge and slowly peel the self-adhesive dressing from the skin. If you notice any redness or swelling around the catheter, any fluid leaking, or if the white cuff is visible on the outside of your body, continue the drainage procedure and then call your doctor or nurse to report what you see. After you've removed the dressing, wash your hands thoroughly with soap and water again for a full minute. Make sure you have a clean, clear area on a table or counter to serve as your workspace. You will want to arrange all of the supplies prior to beginning each drainage procedure. First, open the drainage kit bag and remove the procedure pack. Next, open the procedure pack and remove the blue wrapped bundle and adhesive dressing. Set the adhesive dressing aside and place the blue bundle on your workspace with the folded side up. Carefully unfold the blue wrapping by pulling on the outer edges of the bundle. The items inside are sterile, so avoid touching them. The inside of the blue wrapping provides a clean work area. Remove the drainage bottle and connected drainage line from the bag and set the bottle on the table next to the blue wrapping. Remove the tape from the drainage line and set the covered access tip on the blue wrap near the other items. Make sure you keep the access tip on the drainage line sterile by not touching it and keeping it away from other objects. The access tip should touch only the blue wrapping. If the cover has fallen off the access tip, do not touch the tip with your hands or anything non-sterile. Pick up the gloves by the folded cuffs at the wrist and pull them on. Both gloves fit either hand. Keep your gloves away from non-sterile items such as skin or clothing. Next, open all 3 alcohol pads and place them on the blue wrapping, but do not remove the pads from their pouches. You are now ready to prepare the drainage line and catheter for draining fluid. Close the roller clamp completely by rolling the wheel on the roller clamp toward the bottle. This roller clamp prevents drainage from starting until you're ready. The roller clamp on the drainage line must be completely closed when not draining, or the vacuum in the bottle may be lost. Pick up the drainage line near the tip, twist the cover, and pull the cover off. Set the exposed tip back on the sterile blue wrapping. Holding the catheter near the end, remove and discard the cap from the end of the catheter. Use an alcohol pad to clean around the opening, but don't try to clean the inside. Don't put anything except the drainage line tip inside the end of the catheter. This could damage the valve and allow air to enter or fluid to leak. Do not use scissors or other sharp objects near the catheter. And always remember to keep the valve on the end of the catheter clean and away from other objects to avoid contamination. While holding the catheter, pick up the drainage line near the access tip and gently insert the tip into the end of the catheter. You may feel and hear a small click when they securely connect. Make sure that the valve and the access tip are securely connected when draining. If they are accidentally separated, they may become contaminated. If this occurs, clean the valve with an alcohol pad and use a new drainage bottle to avoid potential contamination. Do not tug or pull on the drainage line. Fluorex drainage bottles use active vacuum technology that provides suction to automatically drain the fluid. The support clip on the drainage bottle maintains the foil vacuum seal until you're ready to break it. To open the seal, steady the bottle with one hand and remove the support clip with the other hand. Hold and push the white T-plunger straight down to puncture the foil seal. Remember that the white roller clamp on the drainage line is still closed. To begin draining, slowly open the roller clamp by rolling the wheel away from the bottle. Fluid will start to flow into the vacuum bottle. You can adjust the flow by moving the wheel on the roller clamp as desired to open or close the clamp. Drainage usually only takes 5 to 15 minutes. It's normal to feel some discomfort or pain when draining fluid. If you do experience discomfort or pain when draining, roll the wheel on the roller clamp toward the bottle to slow or stop the flow of fluid for a few minutes. If you don't feel better after doing this, or the pain is severe, or you have worsening shortness of breath, contact your doctor or nurse. Although rare, pain may be an indication of infection. The flow into the bottle may slow down when the fluid is almost completely drained. It's normal to feel some discomfort as the rate of flow decreases or stops. This is a sign that you have completed your drainage. When you're finished draining, or if the bottle is full, close the clamp on the drainage line completely by rolling the wheel toward the bottle. If you need to use a second bottle, disconnect the drainage line and follow the instructions for connecting a new bottle. You do not need to clean the catheter tip between bottles. Do not drain more than 1,000 milliliters from your chest at any one time. Do not drain more than 2,000 milliliters from your abdomen at any one time. When drainage is complete, disconnect the drainage bottle from the catheter by holding the drainage line near the access tip and the catheter near the end. Then pull the access tip out of the catheter. Clean around the opening of the catheter using a new alcohol pad and twist the new cap into place until you feel a slight click as the cap locks. Clean the skin around the catheter site using the last alcohol pad. Place the foam pad around the catheter. Wind the catheter in loops and hold it on top of the foam pad. Then place the gauze pads over the catheter. The self-adhesive dressing has 3 layers: a printed liner, a clear thin dressing, a center panel, and frame paper backing. Remove your gloves before applying the self-adhesive dressing. Hold the self-adhesive dressing and peel the printed liner from the dressing, exposing the adhesive surface. Center the dressing over the gauze pads and press it down. Do not stretch the dressing during application. Remove and discard the center panel from the backing. Slowly remove the frame while smoothing down the edges using firm pressure to ensure adhesion. Record the volume of fluid drained on the drainage chart or in the Plurex app. Open the roller clamp on the drainage line by rolling the wheel away from the bottle to release any vacuum left in the bottle. Then close the clamp on the drainage line completely by moving the wheel toward the bottle. To empty the bottle, remove the bottle opener and flexible cap by placing your thumbs under the rounded end of the bottle opener and firmly press up. Remove the bottle opener from the drainage line by squeezing the flexible cap and pulling it through the bottle opener. Use the bottle opener to create a larger opening in the foil seal by firmly pressing the pointed end into the foil seal and rotating the bottle once inserted. Empty the bottle into the toilet or sink. Then place the bottle in a plastic bag, seal it tightly, and discard it in the trash bin. Used Plurex bottles cannot be recycled. You should now be ready to drain fluid with the Plurex catheter. Remember to refer to the instructions for use while you are draining to make sure you complete the procedure correctly.
To manage and protect closed surgical incisions that continue to drain following sutured or stapled closure, versatile and portable Prevena therapy is the clear and proven choice. This video will serve as a brief outline of the application of the Prevena Peel and Place 20 cm system, which enables the use of negative pressure incision management on linear incisions up to 20 cm in length. The application of the Prevena Peel and Place system 13 cm is identical to the steps covered in this video. Before applying the dressing, the site should be prepared with the following steps. Once the sterile dressing package is opened, remove the dressing and patch strips using an aseptic technique. Ensure that the small clear bag containing the vac connector is retained if the dressing is to be connected to a vac therapy unit. Gently peel back the center strip on the back of the dressing, exposing the interface layer and adhesive. Center and apply the dressing over the closed incision, ensuring that the adhesive will not contact or cover the incision. Orient the dressing on the patient to eliminate sharp bends or kinks in the tubing. Do not pull or stretch the dressing before adhering to the skin. Remove the remaining bottom adhesive covers by grasping the bottom tabs and gently pulling. Firmly press around the dressing to ensure a good seal where the adhesive contacts the skin. Once the seal is ensured, remove top stabilization layers. Connecting to the Prevena 125 therapy unit. Insert the canister into the Prevena 125 therapy unit until the canister clicks. Canister is fully inserted when the side tabs are flush with the body of the therapy unit. Connect the dressing tubing to the canister tubing by pushing and twisting the connectors until they lock. Begin therapy by pressing and holding the on-off button for 2 seconds. An audible beep and a green light on the front of the unit indicates that therapy is on. Prevena Peel and Place Dressing 20 cm can be connected directly to an approved VAC therapy unit. Approved VAC therapy units consist of ActiVac, InfoVac, VAC ATS, VAC Freedom, and VAC Alta therapy units. Connecting to an approved VAC therapy unit. Insert and secure the canister into the VAC therapy unit and ensure the clamp on the canister tubing is open. Remove the VAC connector from the plastic bag. Connect the VAC connector to the Prevena dressing tubing by pushing and twisting the connector. Connect the VAC therapy canister tubing to the other end of the VAC connector by pushing and twisting the connectors. Set the pressure to negative 125 mm of mercury continuous mode on the VAC therapy unit. Begin therapy. The Prevena 125 therapy unit includes VisiCheck feature, designed to visibly indicate leak level. After the dressing is drawn down, double press the on-off button quickly. The unit will display the leak rate of the system for 3 seconds. The leak rate status should read best, 1 light illuminated, or good, 2 lights illuminated. A marginal reading, 3 lights illuminated, is a sign that a correction of leak is necessary. By avoiding a marginal reading, you can ensure a proper leak level and minimize the occurrence of leak alarm. There are several steps to correct a leak and ensure a proper seal. 1. Press down through the drape onto the adhesive seal all the way around. Use your finger to smooth out any creases or wrinkles. 2. Use excess patch strips along the outer edge of the drape to seal any leaks. 3. Ensure that the canister is securely locked in the therapy unit. Press the canister in fully until the tabs on the canister are flush with the unit. You might hear clicks indicating the canister is fully secure now. 4. Check tubing connectors to ensure that they are fully engaged and locked.
Tunneled central venous catheters are passed under the skin into a separate exit point. So they're considered more stable. They can have 1 or more lumen, and the nurse is not allowed to remove this. You could almost see where it's tunneled through the skin. Tunneled catheters are usually placed in IR. You should be able to see the procedure note in EPIC to determine if the catheter was tunneled or not. If at time of removal you are uncertain, it is best to take the time to review the chart. Implanted ports are tunneled under the skin. They're used for long-term therapies. The tip needs to be verified on X-ray on admission or insertion. We have to have orders to access it and assess for signs and symptoms of infection. Implanted ports are cared for the same way as central lines, except for you lock the catheter with 5 mL of heparin flush prior to removal of the needle. Heparin is not needed if there is intermittent infusions with normal saline flushes every 8 hours or a continuous infusion of at least 10 mL. Routine flushing using no less than 10 mL syringe every shift before and after infusion and as needed. Re-access with a new non-coring needle and change all components of the dressing every 7 days and as needed. Non-tunneled central venous catheters are used for more short-term therapy in emergent situations like surgery or something of that nature. A PICC line is inserted into a large peripheral vein, and then it's advanced until the tip rests in the distal superior vena cava. The nurse can remove this also. Dialysis catheters are tunneled, usually into the superior vena cava. The nurse does not remove tunneled catheters. An introducer sheath catheter is considered a large bore intravascular catheter that is not centrally located. Nurses that can remove central lines and are IMU trained can remove a cordis French size 9 or less. When patients have a cordis, it should never be locked, and there needs to be an continuous infusion running at no less than 10 mL per hour. Central line removal requires a provider order. Registered nurses may not remove tunneled, cuff, or implanted ports, or dialysis or apheresis catheters. Please carefully review the removal procedures. Next, we will watch a quick video that will review some common catheters.
Okay, today we're going to go over the many different types of central line catheters. Some central line catheters here have multiple lumens that you can see here, while some of them just have one lumen. Another thing that you're going to notice here is that certain types of central line catheters have this introducer port right here and right here. The next thing that you're going to notice about these central lines is that some lumens are bigger than others. Typically, the smaller types of lumens over here are around 7 French. Then they go up here to 8.5 French, 9 French. You can get up to 12 French and even 14 French on how big these lines can get. Starting off with these smaller 7 French diameter central lines, you have some of them are just double lumen, and then some of them are triple lumen because they have 3 lumens. The brown port on these catheters is what's called the distal port because the opening goes all the way to the tip of the distal catheter, and I can demonstrate that right now. If I hook something up to this brown port, you're going to see fluid is going to come out right here out of the distal tip. The blue and the white ports on this triple lumen are referred to as the medial and the proximal ports because injecting through these ports, if you come down, that fluid is going to come out through either that port right there or that port right there. Now I want to move on to these central line catheters that have an introducer port. And 2 examples of this are, number 1, you have an 8.5 French cordis or percutaneous sheath introducer. It has 1 lumen here. And the other example here is the 9 French double lumen MAC catheter. The advantages to these catheters right here is, number 1, you get faster fluid infusion because they have a larger diameter lumen. But the other advantage is that it can act as a conduit for something like a pulmonary artery catheter like we mentioned before. The disadvantage to a line with an introducer port is that they usually have less lumens. For example, on the 8.5 French cordis, you can only run fluids. By itself, it has no way to record CVP. But never fear, there's some things that you can do to overcome your lack of ports here. Number 1 is you can use what's called a slick catheter or a single lumen infusion catheter. And so what you do is you just insert this down the hub here of the introducer port. And once you get this on and connect it here, now this is going to allow you to hook up transducer tubing and monitor CVP on a single lumen cordis. So the only use of a slit catheter is if you want to monitor CVP on a central catheter that has an introducer port. The other option that you have to give you more ports when you're using central catheter with an introducer port is to use what's called a companion catheter. And it's just like a regular central line catheter, except for you advance it down here and you're just going to be able to have extra ports. And then the last way to overcome your lack of ports is to insert a pulmonary artery catheter. And you can see when this pulmonary artery catheter is inserted, you've got multiple ports for which to use for infusions and monitoring vascular pressures.
Remove dressing. If blood is present on the SecuriCath device, use a sterile saline-soaked gauze to dissolve and remove it. Gently lift the catheter and the SecuriCath. Clean the insertion site and SecuriCath with cleaning agent. Do not twist or rotate the SecuriCath during the cleaning process. Change your gloves before applying the new dressing. Dress the catheter site per your institute's protocol. The SecuriCath works with all dressings and/or antimicrobial discs. Do not apply the transparent dressing too tightly. Do not turn or twist the SecuriCath from its original position. Be sure to cover the insertion site, the SecuriCath, and any external portion of the catheter up to the extension tubes with the transparent dressing, as this will prevent pulling or kinking of the catheter. There is no need for an adhesive securement device when the SecuriCath is in place. Remove dressing. Grip the hold tab on the SecuriCath with the thumb and finger of one hand to stabilize the device and the securement feet beneath the skin. Pry upward at the edge of the lift tab with the index fingertip of the other hand to release the cover from the base. Apply firm pressure at the insertion site. Fold the wings of the base downward to bring the feet together beneath the skin. Place your index finger on the top ridge of the folded base. Hold the folded base horizontal to the skin surface. Use swift, deliberate upward motion to remove following the shape of the feet. Apply sterile saline-soaked gauze for 3 to 5 minutes at the insertion site. This will soften tissue and make removal easier. Patient discomfort will be minimized or eliminated when the SecuriCath is removed swiftly. Hold firm pressure with one hand right at the insertion site. Think about the shape of the feet beneath the skin. The legs and feet are shaped like the letter L. The legs are 1 centimeter and the feet extend 5 millimeters to each side. Remove following the shape of the foot when using either the fold or split method.
Bariatric sensitivity training, exploring weight bias in healthcare and the nurse's role. Obesity is a complex issue. There are physiological interplay of diet and exercise, genetic factors, environmental, social, psychological, metabolic, pharmacological, economic, and political factors. The CDC statistics for 2018 showed that obesity was 42.4% of adults in the United States, with 9.2% of adults having severe obesity. Non-Hispanic Blacks had the highest rate of obesity at 49.6%, followed by Hispanics, non-Hispanic whites, followed by non-Hispanic Asians. Women had a higher prevalence of severe obesity than men. So what is weight bias? Weight bias involves stereotyped negative views of an individual with overweight or obesity, and it subjects the person to discrimination or unfair treatment. Weight bias is found to be nearly as prevalent as age or racial bias. And in 2014, studies found that overt negative attitudes towards people with obesity were more socially accepted than overtly racist attitudes. Here's just one example of biases against somebody who is obese. So does weight stigmatization occur in healthcare? Research from a 2001 study showed that healthcare professionals had negative stereotypes regarding individuals that are obese. Those stereotypes included things such as being lazy, overindulgent, unsuccessful, unattractive, unintelligent, lacking willpower, and having poor personal hygiene. Another study from 2009, providers identified that they felt that they were poorly prepared to treat obese patients, and they weren't really confident in their ability to help them lose weight. Those feelings were mainly biased on their expectation for obese patients to be non-compliant and lack motivation for lifestyle changes. So what's the nurse's role? The nurse spends the most time with the patients. They tend to be aware of weight stigma. Nurses provide empathetic and respectful care to obese patients, and they often display less weight bias compared to other healthcare professionals. So what factors can be associated with your attitude towards patients who are overweight? Your personal weight status, age, professional experience, gender. More bias was observed by female nurses with lower BMIs. What's the impact of stigma and discrimination? It can lead to increased anxiety, ineffective communication, increased body image dissatisfaction, and can result in several psychological impacts, such as binge eating, social isolation, and delaying or avoiding seeking medical care in the future. So how to reduce weight stigma? Patients may have had previous negative experience with healthcare professionals, so you just need to approach them with sensitivity. Just recognize that obesity is a complex issue and that we need to communicate well with our colleagues to avoid stereotypes and model this behavior when precepting or with students. Try to explore all the presenting problems that the patient has, not just their weight. Recognize that patients have probably tried to lose weight repeatedly. Emphasize behavior changes rather than numbers on a scale. Acknowledge the difficulty of lifestyle changes. Recognize small weight loss and the significant health gains. Create a supportive environment. Make sure that you have appropriately sized equipment for your patient. Strategies to overcome obesity include self-reflection on your own personal biases that you may have. Try to adopt supportive communication and language. Emphasize achievable behavioral goals. Choose your words wisely. Use people first language. Don't label a person based on their disease. Make sure to have a supportive environment where there is appropriate seating, bed, equipments, gowns, things like that. So lessons for overcoming bias: have an awareness of your own beliefs, identify and overcome your own biases, provide care with compassion, and attempt to understand the individual's unique experience. Nurses should be a positive influence as leaders to their peers, students, and public by role modeling unbiased attitudes. Just a quick review. We have been recently having a lot of patients coming to the floor and getting gum from either dietary or from the PACU. Bariatric surgical patients, whether it's the sleeve or bypass, should never chew gum, even if they are on that ERAS protocol, which is the early recovery after surgery. The patients should only be drinking water, broth, and tea, those three liquids, until they have their barium swallow, and then they can have a sugar-free, clear liquid diet after that. They should not use straws. They should not have carbonated beverages, and they should not be chewing gum. That's forever. That information is given to patients preoperatively in the clinic and again when they are discharged.
The hover mat is a friction-reducing device that is used when a dependent patient's weight or girth poses a potential risk for the caregivers when performing lateral transfers and repositioning. The hover mat can reduce a patient's weight by 80 to 90% and comes in 3 sizes, 34, 39, and 50 inches. The hover mat is breathable and can be left under the patient. Place a sheet or chucks between the hover mat and the patient. Do not inflate the hover mat if the patient has a suspected thoracic, cervical, or lumbar fractures. If the patient has suspected thoracic, cervical, or lumbar fractures, the hover mat may only be used if the patient is on a spinal board and the hover mat mattress is under the spinal board. If you're using a single patient use hover mat, discard the hover mat if soiled or if the patient has been discharged. How to use the hover mat. First, check to make sure the bed's brakes are in lock position. Log roll the patient side to side to place the hover mat under the patient if the patient is not already on the hover mat. To make sure the patient is centered on the hover mat, align the patient with the red mark at the foot of the hover mat. Check to see if the patient's head is off the edge of the hover mat. To prevent hyperextension of the patient's neck, have the patient's head about 2 inches below the top of the hover mat. Connect the safety straps. You do not have to tighten the straps after they are clipped in. Plug the air supply power cord into an electrical outlet. Insert the air supply hose nozzle into either hose ports located at the foot end. Snap the hose into place. Fold the Velcro over the hose. If performing a lateral transfer, transfer from a higher surface to a lower surface. To turn on the air supply, press the green button for hover mats labeled as 28 to 34 inches. Press the brown button for hover mats labeled as 39 to 50 inches. Wait until the hover mat is completely inflated. Holding onto the red handles and using proper body mechanics simultaneously with the other healthcare worker, reposition the patient. Turn off the air supply by pressing the standby button. Unclip the safety straps. The hover jack is used to raise a patient off the ground without manually lifting. The hover jack has a weight limit of 1,200 pounds and should not be used for patients that are experiencing thoracic, cervical, or lumbar fractures unless used in conjunction with a spinal board. The hover jack is designed to be used with the hover mat. Place the patient on a hover mat by using the log roll method. Connect the safety straps and inflate the hover mat. Pull the patient onto the deflated hover jack and then deflate the hover mat. Connect the hover jack safety straps over the patient but do not tighten the straps. The red cap valves should be tightly secure before inflating. Connect the air supply hose to the valve labeled valve number 1. Press the button on the air supply labeled as hover jack. Once valve number 1 is completely inflated, you will hear a change in air pressure. Continue in numerical order until valves number 2, 3, and 4 are completely inflated or the hover jack has reached the desired height. Disconnect the hover jack safety straps and inflate the hover mat before laterally transferring the patient to the bed. To deflate the hover jack, unscrew the red caps. Clean the hover jack before and after use with hospital-approved disinfectants. The Galvo sling lift is used to mobilize dependent patients to and from a wheelchair, bed, toilet, or the floor. The Galvo has a max weight limit of 440 pounds. The Galvo lift is only to be used with the Galvo sling. The sling size is matched with the color located on the Galvo. When using the Galvo sling, make sure the bottom of the sling reaches the patient's coccyx or tailbone area and the sling leg straps are crisscrossed. To To prevent tipping, do not lock the wheels of the Galvo unless on an uneven surface or lifting the patient from the ground. When lowering and raising the sling bar, press the up and down button located on the Galvo remote. When adjusting the base to maneuver around obstacles, use the Galvo remote. In an emergency, manually lower the Galvo by moving the emergency red handle up and down. Clean the Galvo before and after use with hospital-approved disinfectants. Remember to charge the Galvo after every use by plugging the charger cable into a power outlet. You must unplug the power source when using the Galvo. Sabina 2 is a sit-to-stand lift used when the patient has difficulty standing up on their own from a seated position. The Sabina 2 has a max weight limit of 440 pounds and is a great tool when transferring a patient to a wheelchair, bed, toilet, or participating in early mobilization. The patient must have some leg and arm strength to use the Sabina 2. First, unplug the Sabina 2 from its power source. The patient needs to place their feet on the footplate. The patient's shins should be resting against the leg support, and the top of the leg support should be just below the kneecaps. The sling size reference is located in the quick reference pamphlet and on the lift. The sling should go around the patient's back, under the arms, and make sure all sling straps are secured in the sling hooks. The patient's arm should be on the outside of the sling. The patient should be holding on to the sling bar. Similar to the Galvo, you do not have to lock the Sabina 2's wheels unless you are on an uneven surface. Use the hand control to raise the patient up or down or maneuver the base around obstacles. While lifting the patient, encourage the patient to lean back into the sling and have them push with their legs. In an emergency, pull the red emergency control to lower the patient manually. Clean the Sabina 2 before and after use with a hospital-approved disinfectant. Remember to charge the Sabina 2 after every use by plugging it into a power outlet.
The roll-on device is for patients who can get from a sitting to a standing position with minimal assistance. There is a label with the weight. The red handle locks the back support in place. The shin guard can be adjusted using the screw-like device to raise it up and down. The legs of the device can also be adjusted to fit around larger furniture. The wheels of this device have locks. When you are getting ready to get the patient up, bring the device towards the patient. Have the patient put their feet on the plastic plate. Lock the device. Have them scoot forward so that their shins reach the shin guard. Next, adjust the shin guard so it is right below the level of the knee. Have your patients reach for the handrails and assist them to a standing position. Make sure to close the back support and lock it with the red lock. You'll need to unlock the wheels, and now you can move your patient. When it is time to bring your patient back to their chair, lock the brakes, open the back support, make sure to have one hand on the patient, and gently assist them back into the chair. Additional bariatric equipment is available. The Steady Aid for patients up to 700 pounds and is used for sit to stand lift and is located on 3 West. The Viking is a total lift, can lift patients up to 660 pounds, and that is available on 3 East. And the last piece of equipment is the Titan X, which holds up to 1,000 pounds and is located on JMC 4th floor.